Good evening to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. K. Suresh, sir. Sir is MD, DIH, DF, FIAP, FIPHA, FISCD, family physician, public health consultant, Bangalore, and visiting professor of practice at KSR, Karnataka. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is describing in the elderly practical approach for the physician. Now, without any further delay, I would like to welcome Sir again at our forum and would like to hand over the session to him. Over to you, Sir.
Okay. Good evening, ladies and gentlemen. Today's discussion is something related to my generation of doctors. As you know, I am aged about 82 years, and we are talking of not prescribing but de-prescribing for the elderly people. We all know the elderly people are compelled to take multiple drugs for various chronic illness, which we consider in next few minutes. First, let us understand what do we mean by de-prescribing the drugs, for particularly in the context of elderly. Basically, it is a structured, shared decision-making process that identified and tapers potentially inappropriate or harmful medication, which also includes over-the-counter drugs, for improving the health outcomes and reduce adverse events. Basically, it involves reviewing all medication. Therefore, I would say that this is the task of general practitioners. In the current trend of, particularly in urban area, people seeking care directly with the specialists, this problem is increasing because multiple specialists prescribe different drugs to their choice of commercial products. In the process, there could be duplication or even multiplication of certain drugs. So, as a general practitioner, in the interest of your patients, you need to first review all the medication, including OTC, the person is taking, to identify what are the high risk and low benefit items in them. Comprehensive review is basically it is looking at the what we call as a medication audit or reconciliation, including supplements and over-the-counter. Look at these supplements, over-the-counter drugs, and also add certain diet items. Sometimes the dietary items can change the whole outcome of the drugs given. For example, recently I had my own experience just last week. I ate of some vegetable, green vegetable, which is known to be a so therefore we need to be careful, including even the dietary supplements or diet taken on a given day. Out of them, you may have to identify high risk drugs and start tapering slowly. That's the important thing. Start tapering slowly. This, of course, the decision has to be made with engaging the patient and sometimes the caregivers, because this elderly patient may not be following their medicine due to the memory loss. Somebody in the family may be assisting. Basic principle we use is stop slow, go low. That is, reduces doses gradually. For example, if they are on benzodiazepines, you may take about 4 to 6 months to withdraw completely. And you need to address one drug at a time, thinking which of those can be slowly dispensed with. And of course, close monitoring is a must. One need to keep an eye on ears on the withdrawal effects and symptoms of recurrence of the original condition of which the drug was prescribed. There are different tools used. Basically, we talk of two criteria. One is Breed's criteria. This is an American Geriatric Society's recommendation. What it does is it classifies all the drugs into three categories. Medication to be avoided in general, like they may be antihistaminic, antipsychotic, barbiturates, benzodiazepine, etc. Medication to avoid in specific conditions like NSAID in kidney diseases, heart failure, and antipsychotics in dementia. Third category is the drugs to use with caution, like diuretics, anti-epileptics, etc. And there are fourth category is drugs which have drug-drug or drug-disease interaction. Multiple CNS active drugs or warfarin with NSAID. The second criteria is what is called as a stop criteria, which is screening tool for older persons, potentially about the inappropriate prescriptions given to them by multiple practitioners. What this criteria does is goes by systems of the human mechanism like cardiovascular, CNS, GI, musculoskeletal, etc. And in each of these categories, they recommend what are the drugs to be completely avoided, given with caution, or may have side effects and keeping them in the mind. Now let's come to first understand why are these multiple drugs are a problem in the elderly. First criteria is, as we know, elderlies have multiple morbidities simultaneously. For example, I myself have cardiac problems, hypertension, diabetes, prostate enlargement, etc. So the common conditions in Indian population starts with high blood pressure, which half of them may even not even know that. Diabetes is becoming a larger problem of late. Linked to diabetes are the two other common nutrition deficiencies, which is vitamin D and vitamin B12. Sleeplessness or insomnia for various reasons, basically being alone, loneliness, or financial instability. Arthritis could be rheumatoid or osteoarthritis, high cholesterol, asthma, COPD, coronary artery disease, osteoporosis, and vitamin deficiency as indicated. So these are the reasons for polypharmacy. We call polypharmacy when a person has to take more than 5 drugs. For example, in my case, I have to take daily about 7 drugs for various conditions which I told. So here, why does this problem is becoming more common in urban areas where people run directly to the specialist and the general duty doctor or family physician concept is slowly waning. So, because of the multiple morbidity, they often go to different specialists. Senior, most of them, since they construct, what happens is each of those specialists gives a fragmented care and provides prescription without considering the other doctor's prescriptions. Then there is a second issue, what is called as prescribing cascade, which means you prescribe one drug and you it takes some action which has some reaction. For that, you give another medicine. For example, if you give for knee pain some analgesics or bufen, automatically the doctor adds an antacid, thinking that it might lead to gastritis or esophagitis. There are physiological changes as age advances, which reduces the renal and hepatic function and lowers the metabolism, increasing adverse reactions requiring more treatment. In some cases, particularly in rural areas or even urban retreat, what we call a self-medication. Today we have WhatsApp University, Facebook, YouTube, everybody recommends some or the other medicines along with some other exercises. The people want to experiment and taking over the counter drugs because that saves them consultation fees. Then, as you grow, preventive care becomes aggressive. Supplementation of vitamin D, calcium, B12, anti-cholesterol drugs, etc., etc. All these five are the reason why polypharmacy becomes a norm of the life than exception. What are the risks of taking too many medication? Basically, we classify them into five groups. One is dangerous drug interactions. If you take too many simultaneously or within a short gap, each drug may be less effective and along with that might increase the side effects or to the extent that may create a new health problem. For example, if you are giving blood thinner warfarin, it can interact with antibiotic, making bleeding more likely even with the small injuries. And injuries, as you know, are very common among the elderly because the frailty, frequent falls. Then there is an interaction which compels older adults for hospitalization. This is one of the common causes of hospitalization in the elderly nowadays. Second, increased risk of the falling down. As I already told, many medication can cause dizziness and drowsiness, particularly opioid pain relievers, anti-anxiety drugs, antihistaminic like Benadryl, even blood pressure medication may cause what is called as thermostatic or postural hypotension, which increases when you stand up, the person feels giddy, and if he doesn't take support, might fall. When combined with effects, they become stronger, greatly increasing the risks of dangerous falls. There is a common phenomenon with senior citizen head banging, banging syndrome. Every time they bang their head to something which they come across unintentionally. Then there is cognitive problems. Some medication can cause confusion and memory problem, especially true for anticholinergic drugs, which you generally use for bladder problem and allergies, sleep medications, And the prescribing cascade happens when a doctor prescribes a new medication to treat side effects of the other one. For example, a person complains of nausea or vomiting, you prescribe anti-antiemic. It may lead, which causes drowsiness, and doctor prescribes some stimulant, and the cycle goes on. This cascade can quickly lead to polypharmacy and the consequent problems. There are other common problems like poor medication adherence. It is known that 50% of the world take medication prescribed on their own, basically because some avoid because the cost. This is very common in rural areas where the financing is a problem. Either they reduce the take, or if you advise 3 times, they may take 2 times. Basically, it is to minimize the cost. Second is complex schedules are prescribed. If you look at any prescription, there are OD, BD, HS, TDS, and whatnot, and there are quite a figurative indications nowadays. People put different figures, making illiterate people to understand. And then there are physical challenges among these people. Arthritis may make it difficult to open the pill bottles. Poor eyesight may make the reading labels difficult. Memory problems and fear of side effects. 20% of the people stop taking immediately because they say side effects. Of course, there are some rare reasons like inappropriate medication. If the doctor prescribes maybe antihistaminic or benzodiazepine for elderly, they are known to cause, and including muscle relaxant, they cause more harm than benefit. There are medicational error by mistake. One may wrong the dose or even the medicine. Our handwriting may be difficult to understand for the pharmacist. He may give similarly sounding medicine. So these are 5 systems of illness which clutch the weak memory of the elderly. One is mobility, because people have to be mobile if they have to be active. So if people focus on safe and independent movement, addressing their gait, balance, fall prevention, and restoring function through physical therapy is one important thing. Mind augmentation, that is, one should screen and manage the cognitive issues like dementia, delirium, depression. This is crucial for overall mental well-being. And there is multi-complexity. This must be managed because of the multimorbidity and complex biopsychosocial situation, ensuring the treatment does not conflict with each other. What matters most is patient-centered prescription, keeping in mind patients' personal health goals, preferences, and values, and local community averages of biomarkers. Very often, with the laboratory-dominated practice now, small deviation in be it anemia, cholesterol, vitamin deficiency, prescriptions are made left and right. And we all know these automatic machines are made for international standard, not Indian standards. Therefore, one need to look at some local standards and stick to the international standard strictly. Medication, polypharmacy, deprescribing unnecessary drugs, or optimizing prescription and identifying harmful side effects to reduce the medication burden. This basically means 5 or more prescription drugs at the same time. Nearly half of all older adults in India today face this issue, which can lead to dangerous side effects and drug interaction. I'm going through a few case reports which either I have come or literature talks of that. First one, adverse drug events. Now, first case comes in where a methotrexate tablet given to a 61-year-old woman developed Stevens-Johnson syndrome. Hope you know this is fever, rash, and blisters, following which she required intensive care and drug discontinuation. In an institution, tertiary care institution, a 71-year-old male was given a bupivacaine for spinal anesthesia. Because of 0.5%, he went into sudden shock, needed further, that was, had gone for a simple hernia operation, and he had a shock and had to be maintained in intensive care unit for quite some time. A 70-year-old patient of mine developed bronchospasm suddenly and laryngeal after taking ibuprofen for rheumatoid arthritis. Managing that took about 20-30 minutes. Of course, after that, we stopped the drug. Isoniazid, usually given for tuberculosis patient, 74-old lady was prescribed for nodal tuberculosis, that is lymph node tuberculosis. After some time, it started in about a week's time, signs of liver toxicity, which was confirmed by laboratory kitchen. And again here, because of the slow metabolization, the drug had to be stopped. Another 80-year female developed drug reaction with eosinophilia and systemic symptoms called as DRESS, featuring a diffused rash and exfoliation. After treatment with multiple antibiotics, including ceftazidime, this is published in the Frontiers, and tacrolimus induced aplastic anemia, a rare case of bone marrow aplasia. AC inhibitor and chemotherapy in an elderly cancer patient again created problem. This is an institutional case. Now, second sort of errors is by medication errors, where a 72-year-old retinoblastoma case in one of the ophthalmic institutions went for enucleation. The anesthetist mistakenly administered 200 mg of thiopentone sodium instead of 100 mg, and it resulted in unintended prolonged respiratory support for over 10 minutes. A wrong drug selection, a physician, an internal medicine person, wrote something and his writing was not good. Therefore, what happened is these were, instead of his using his own knowledge, in Tamil Nadu, I am talking about 20 years ago, computers use, the hospital doctors are supposed to drop down menu based on the technology. They would write and drop down menu comes in and they prescribe the drug. But what happened in this case was the person, instead of prescribing something, he gave a altogether different medicine which was intended not for the condition he was in. So this is the devil of computers, automatic thing. Beware of AI coming in. These are going to be common errors. Then there is a dosage frequency omission. I already talked. 20 to 30% of our Indian patients omit a dose or the quantum of dose you have prescribed in each dose just to be cautious. More for me, I will take less. Then, of course, illegible prescription where pharmacists can make a mistake of giving one item to another. And if the patient does not come back to us, he may keep consuming the medicine for 2, 3 days, complain that doctor, you prescribed something, it's not any helping me. Sometimes there are contradiction drugs are prescribed, which usually, for example, NSAIDs for a 70-year patient with a known history of peptic ulcer, you know what can happen. The gastrointestinal bleeding. And if not documenting allergies, nowadays one has to be careful, either allergies or if it is not documented, particularly if there are low patient people who have minor surgeries, you have to be careful. Then misuse and addiction is another category where multi pharmacy may go wrong. An 81-year-old man with a history of using alcohol, tobacco, cannabis, exhibiting antisocial traits, he sought a high engaging the snake bite for recreation purposes, fed with a white powder, susceptible to a combination of psychotropic. He required special de-addiction services to manage dependency. He was driven by a need for alternative courses and took on 6 months to come back. Similarly, substance misuse and severe opioid and cocaine addiction. These addictions keep on changing drugs, more and more concentrated items can create time. And sometimes we fall into misleading drug promotion. Flex, I can remember way back in 1982, it's about 15 years after I had started. It was highly recommended for arthritis. Now, what happened is the campaign led to heavy use of this by elderly patients, leading to widespread liver and kidney damage and deaths. So the drug was pulled from the market. Similarly, in India, we can give many of these examples. Ramdev's drugs, antipsychotics, and sometimes direct to consumers. A study of age group of 63-82 who took drugs viewing television ads of 12 to 15 participants misinterpreted information. They believed medication could replace necessary lifestyle changes instead of going for walking and diet. They thought medicine will do all wonder, as we know in Indian cultures. लाख दुखों की एक दवा है. Then, of course, there are unsubstantiated promotional claims. People claim so many things. We know all of that. Every day there is a thing. And a recent drug controller findings indicate in India that 88% of our advertisers selling drugs on social media fail to provide fair balance and therefore disproportionately impact vulnerable elderly. Irrational prescribing trends. A study in last year found that 56% of elderly patients experience polypharmacy, out of which 13% took more than 5 drugs, 10 drugs. Another analysis indicated that about one-third of patients had at least one PII. Commonly misinterpreted medications are NSAID and anticholinergic, proton pump inhibitors, and cardiovascular agents. So the multiple prescription, this is what I was talking about, the current trend of running to the specialist. An elderly patient with multiple comorbidities discharged a complex regimen experienced during recently, which led him to including QT prolongation and a significant fall resulting in femur fracture. The incident was attributed to interaction among multiple prescription medication, including a failure to manage combined use of sedatives, hypnotics, and cardiovascular agents. My own case recently, for the last 6 months, an elderly male of 76 years who has been in the habit of taking brufen for rheumatoid arthritis over 20 years, as and when he really, no rationale, but whenever he had more pain, he would take it. Slowly, he developed hypertension, and the hypertension became resistant hypertension. Therefore, we had to have three anti-hypertensive drugs that resulted into CKD. Now, the four prescriptions he got, one from rheumatologist, another from a practitioner, third a nephrologist, and fourth a cardiologist. And an analysis indicated that of the drugs were written by all of them. Person wrote each drug of a different trade name. Totally, there were about 14 drugs. By just doing an analysis of all this prescription, I could reduce it to about 7 drugs in all. So one need to be careful. General practitioner is becoming increasingly more important, but unfortunately in the urban areas, the general practitioner's role is becoming low. So what can we do? How can we help? There are so many tools, but again, these are urban phenomena. In rural area, one may not have access to these. Weekly or something in front of a paramedic, and the person take based on the color or the notches in which they are put. Then making a medication list every time, including OTC drugs, what to take, how much to take, when to take, etc. Smartphone apps now have apps. The apps are a common thing nowadays for everything. From ordering a cup of coffee just underneath our apartment to many other items. For Indian rural practice and general practice, I feel better communication is the only way out. What we need to do is do all prescriptions they have from different specialists, check the duplication, if any, as I told you what we did, check for possible interaction and inform the patient that the side effect may happen, simplify the medication schedule, finding alternative to risky medicine. To do this, we have to follow 5 steps. Bring all medication bottles, ask the patient to get you, bring all medication bottles or strips when they come to you with an appointment. Tell each specialist doctor about medication prescribed by others. Include supplement and over-the-counter drugs in medication. Ask questions about prescription. Test patients' or patients' understanding of the schedule by asking questions which are not leading questions. So this is important to have understood. Don't ask, will you take it 3 times? Best question is, how often you will take this drug? How much you will take? How often you will take? This type of practical questions. And be confident. If you are a busy practitioner, hiring a counselor makes sense. These are some common drugs which in my practice are considered for deprescribing. Antihypertensive. The current treatment recommendation from the global recommendation for whether we generally follow USA or UK is what used to be the traditional when we did our graduation in late 60s is starting with one, going to increase depending upon the need. But today, both in diabetes, hypertension, many other chronic conditions, right at the first assessment, based on the existing condition, multiple drugs are prescribed. So therefore, one need to see, as I was telling you, that person, my patient, where we had started about 3 drugs, we narrowed down to one after about 2 months. So one need to consider tapering the systolic blood pressure to around 150. Don't be strict of 140, 130. In patients which are my age, that is 80 plus, 140 in patients which are more than 60 years. Especially if they are frail patients. All have learned in pharmacology, but nobody practices. The dose to be prescribed based on the weight of the body, but we hardly practice. Second set of drugs is benzodiazepines. These drugs have to be stopped slowly to manage the risk of sedation. TPIs reevaluate the long-term use. They are not supposed to use for more than 2 to 4 weeks. Antipsychotics and sedatives, they are targeted for reduction in long-term care settings. The polypharmacy problem in India, as well as 2024 analysis, with a mean age of about 69 years, on an average, an individual every 60 years takes about 6 drugs: diabetes, hypertension, rheumatoid arthritis, prostate, if it is man. 27% of them take additional over-the-counter herbal medication because somebody would have told them, Ayurveda helps you better, homeopathy helps you better. They would not reveal it to the allopathy doctor. Basically, there are different studies which indicate that about 40 to 50% of hospitalized elderly patients were using nearly 10 or more drugs. Now, for deprescribing, there are different tools to be used. For Indians, a recent study was done by what is called as the Delphi method. I'll come what Delphi method. Started with 63 drugs and finally ended with recommending 52 drugs in 3 categories. I will also expose the list of these drugs soon. First is generally for all elderly, avoid these drugs. There are about 39 items when they started. Herbal drugs 5 and other drugs 15 allopathy medicine. Now what it does, the Delphi method is, it uses key experts based on their experience and one asked question. It is an interactive process, allows 2 to 4, eliminating one after another. There is a controlled feedback after each round. The facilitator provides a summary of the panel's views. Ultimately, a consensus is built to recommend or reject a particular drug. It is widely used in forecasting, strategic decision making, and policy formulation, and also in prescribing the medical drugs. Now, this is the process which is done here. Can you see? They started the section 1, 39 drugs. Second was 5 herbal drugs, and Section 3, 19 drugs groups to be avoided in renal dysfunction. So totally, when they did in the second round, they rejected 3 out of the Section 2, and finally, in this last round, they accepted only 52 drugs. You can see some of them which were initially included were excluded, and some additionals were also added. So basically, this is a process of taking the experience of people who use these drugs. Now, as of today, we have 3 categories of drugs. Group A is called as drugs with anticholinergic action, general statement. Here, there are tricyclic antidepressant, potent anticholinergic action, antipsychotic drugs, potent anticholinergic, skeletal muscle relaxant, anticholinergic, anti-Parkinsonian agents, antimuscarinic of urinary incontinence, gastroenteric, antispasmodic, and anticholinergic. So, seventh item was first generation antihistamine. We avoided in general for all senior citizens. In the second category, Group B, there are sedatives and hypnotics, basically barbiturates, benzodiazepines, non-benzodiazepine, etc. And in Group C, drugs Group D, analgesics, despite in the section which has herbal drugs, there are certain descriptions are there item-wise. Similarly, in section 3, there are drugs which should be avoided if there is renal dysfunction. These include about 14, 15 drugs. You can see the anticoagulant and bisphosphonates, digoxin, diuretics, etc., etc. So there is a ready-made list where one has to be careful in using. I will not go into these individual lists. You can verify the list. One other which might be facing is in community dwelling. Nowadays, old age homes are becoming common in every district headquarters. So here, one need to look at deprescribing in community dwelling older adults. Basically, we need to look at enough polypharmacy, because here, whatever one person does, the other person also actually copies. It is needed to avoid adverse drug reaction. There are about 45% of Indian doctors who use what is called a stop-start criteria, while others use Beer's criteria, which we already described. So these are some of their reference. With this, I stop my presentation and open for the discussion. Thank you. Secretary, no. Hello?
Hello, sir. Yes, sir.
Shion, take over.
Yeah. Thank you, sir. Thank you so much for this wonderful presentation. We did receive few questions from our audiences. If you like to take that up.
Yeah, sure.
Uh, so the first question is: discuss its clinical importance in elderly patient with polypharmacy and explain how it differs from the routine medication review.
See, in clinical practice, as I was told, the particular, when I say urban, now I can go even up to tehsil level, not only major cities, district headquarters, and even tehsil. People directly run to the specialist. sometimes even a super specialist. And each doctor has his own favorite traditional names. So there are three possible things overlapping. One, same drug, different commercial name. Another thing is a cardiologist prescribes whatever is required for his cardiological and also says, okay, you are also diabetic, let me add one diabetic drug. Or let me add one for your joint pain. So he also adds drug. So imagine if you have gone for three or four people. I give an example of one of our person. Three people needed 14 drugs, which could have been cut to 7 drugs finally. So therefore, as a clinician, general practitioner have a role to look at all those prescriptions. First, avoid multiple drugs or commercial names of the same drug. Second, dosage, you see whether combination and permutation sometimes go beyond requirement. And some drugs add more than one they are meant for. Suppose you give an analgesic and antipyretic. Analgesic, people think it helps only for pain. No, it also helps for fever. Now, fever also helps like this. So, one needs to the clinical thing. That's why I keep saying the role of general practitioner is very important in reviewing all the prescription because people don't understand. Even a literate person, I know since I work long for UNICEF, all my Delhi colleagues today complain to me, sir, where are the general practitioners? Delhi doesn't have any general practitioner. They're all specialists. I said that becomes more important. So either you learn, look at the drugs, what is the chemical formula, whether there is any duplication, does the dog increase? One is, as I told, first is the same drug. Second is dose. Third is, there is what is known as the drug and disease interaction, drug and drug interaction. You are taking one drug for some disease, it may affect another disease either positively or negatively. Similarly, two drugs when come taken together may not give effective of each one. Therefore, for example, some of the diabetic practitioners, for example, me, I would not prescribe a combined drug of 2 or 3 drugs because each one of them goes down their effect. So ask them to take, if there are intelligent patients, ask them to take separately each drug, whatever time before, after, etc. So I think the clinical role becomes more important for the family physician. Pediatric specialist doesn't think too much. He basically their diagnosis nowadays depends upon what we call as imaging biomarkers. Imaging means the moment you go, I just had yesterday one patient in Bangalore City came with lot of investigation, everything, all scanning, abdomen, brain, everything was done. The main complaint was losing balance. That's all. Person was losing balance and ataxic or whatever we call. So only one positive thing is vitamin D was severely low. The moment we gave it for just 2 weeks, almost the person is now 70% better. So therefore here clinical acumen is equally important in prescribing drugs. Next.
Thank you, sir. Thank you so much for explaining such wonderfully. So there is another question, sir. Describe the structure approach to descriptioning in elderly patient.
Yeah. Structured approach means first take all the prescription given by the qualified doctor. Also find out what are the other things which they are taking on the counter. Because nowadays, supplementing with vitamin D, vitamin B12, B complex, iron, particularly among the elderly, ताकत नहीं है, ताकत की गोली दो और कुछ हो गया और एक गोली दे दो. Then you have other systemic medicines. Homeopathy says this is not harmful, you can take this also. Ayurvedic person says this. So when we talk of systemic or strategic analysis, we need to take each other and analyze three things. Which of them can complement each other and minimize either a dose or drop one of them? Which of them will contradict each other, interaction among themselves to avoid one of them which is least important? And then ultimately look based on the clinical symptoms, what are the minimum drugs which can cover the other conditions the person is suffering from. Do not general prescribing do a review today for every condition, whether it is hypertension, diabetes, joint pains, lung disease. There are minimum 2 to 3 drugs each doctor prescribes. One antibiotic, one sedative, one cough syrup, like that. So one need to do this permutation and combination and make a simple schedule for them. And for elderly patient, what is more important is not only the patient, try to help make the attendant to understand, because they may not remember, they will forget. So one of the family member need to be also educated. Next, please.
So there is one last question. What tools and criteria can assist physician in identifying inappropriate medications in elderly adults?
Now, I already presented in my thing. There are two ways of doing things. One is described on systematic. That means cardiac system, respiratory system, what are the drugs, and those drugs, how they can complement the other system also, or sometimes they may be opposite to each other. That's one way of looking at individual. Second one is categories of drugs. Again, using that, for Indian practitioner, it also becomes to complement the indigenous system of drugs, homeopathy and Ayurveda, the medical allopathy man may not know. But it's time for us to learn what is the effect of those drugs. I also gave an example. Just last week, overnight, I ate salad of only mooli. See, mooli leaves and moolies are known to be diuretics. I'm a diabetic. That night, instead of going once in the midnight, I had to get up 5 times. The moment you know how they complement each other, you will be able. So, therefore, my suggestion is when we say medication, it's not allopathic medicine alone. It is all medicines, over the counter drugs, nutrition supplements, and even the dietary habits. All need to look how they compete each other or complement each other. Then only you say what needs to be done.
Absolutely, sir. Thank you so much, sir, for answering all our questions. That's all from our audience, sir. So, as I'm about to conclude, any take-home message from your end, sir?
No, my only request to all practitioners is, as a general practitioner, one should take these things under their control, because ultimately, as a family physician, they have responsible for the entire family's health, and not antagonize the specialist, but try to see that the prescription complement each other, not counteract and disturb the health of your patient. Thank you very much. Thank you to all the listeners and to you, IJCP, for the opportunity.
Thank you so much, sir, for joining us today. And with this take-home message, I would like to conclude today's session. Thank you so much, sir, for joining here. Thank you, sir.
And bye.